Good afternoon to all and a warm welcome. At the outset, I'd like to thank Dr. Nirmal and AIOS for this opportunity. So my talk for the day is about my experience in managing an emergency situation the first time. Okay, so ophthalmology is one of the fields where we deal with a number of geriatric patients, both in your theater as well as in the OPD. So unfortunately, as an ophthalmologist, we do not deal with medical emergencies on a daily basis. Hence, we are not actually well versed with them. And also our staff whom we train sometimes are also not as equipped to deal with these medical emergencies, and there's a panic all around. As you have seen in India, most of the ophthalmic centers are a daycare facility, which is usually run by a single or a couple of doctors. One doctor is in the theater and the other doctor is in the OPD. And in a case of a code blue situation, sometimes the staff are also not equipped to deal with them. For a simple reason is that they are not equipped or because they're not trained. So being this as a background, I'm going to share to you my experience of how I managed a code blue the first time when it occurred. To give you an overview, I started my practice in 2006. In those days, I never used to have an anesthetist standby during my surgeries, and fortunately, I didn't have any problem at all. Then we upgraded our facility, and we didn't have any problem for a couple of years. Then this is what happened for the first time. So this was a 64-year-old female who was posted for a second eye surgery. The first eye surgery went 1 week prior without any problem. So she reports to us for the second eye surgery, the reception. We normally check a blood pressure when she checks in. We also see whether she has taken all the medications, whether she has dilated the drops, and she was shifted to the theater. And everything was done. Our anesthetist also came and had a look. Everything was normal. Then she wanted to use the restroom because she was a third or fourth in line. And she came out of the restroom and suddenly she became breathless and she fainted. So this is what is the scenario which has happened. And then we had to activate the code blue immediately. And we were lucky because it happened just outside the theater. So we really didn't know what went wrong. So we went back to really assess this patient on what happened to him. So this was a patient who presented to us on an evening OPD. The patient had come from Kanjipuram. She had a systemic history of hypertension, and she had a bilateral cataract, and we went ahead and did all the investigations as far as the ocular is concerned. We also did the basic blood investigations, like ECG. We did take a consent. We did look into it all superficial, and we found everything was normal. The first eye surgery was very uneventful. Everything went on fine. She presented to us on the post-operative day. Everything went well. So going by this, we went ahead and fixed her for the second eye surgery. And before that, I already told you, and she fainted just before she went into the theater. So code blue was activated. She was shifted in the OT. By that time, I decided to always operate only with the anesthetist. See, auscultation revealed rales and bronchi. Her BP was high. Her oxygen saturation started dropping. So we started her on an IV line, injection Lasix and nitroglycerin. And we did have an ambulance, a protocol, and the ambulance was called and it arrived within 5 to 6 minutes, and we shifted the theater. So the theater anesthetist notes indicates all this which I've said now. Reviewed the patient was received in the ICU. I myself accompanied the patient. It was a multi-specialty hospital located around 500 meters from my block. Artificial ventilation started, all the patient's vitals stabilized, the cardiology was informed, and we stabilized the patient and we came out. But unfortunately, within a couple of hours, the patient vitals started dropping, and it was very unfortunate we couldn't revive the patient back. So what really went wrong? So we went back and we saw what were the things which we could have done better or what we missed. So initially, it was an obese patient. We didn't look into her medications seriously. We just did a superficial checkup. We found that all her initial investigations were normal. And adding ice to the cake, the first eye was very uneventful and things went better. So initially, during when the code blue was activated, we did have a problem to decide whether it was status asthmaticus or an acute MI. We had difficulty in finding an IV line because at those days, we didn't give an IV line to all our patients. There was panic all around because the first time we were facing a code blue situations. And the other difficulty is that we had difficulty in shifting an obese patient on the stretcher because we didn't have adequate staff. So unfortunately, when we went back to see what had happened, our CCTV camera in that particular floor didn't function, and we were not able to record the events. and the emergency notes has to be in place and follow up. So these were the deficiencies we had. So whenever you see a patient, we have to have a high degree of suspicion, follow the protocols, always have a IV line in place, or whatever kind of surgery it is, whether even if it's a cataract surgery, always have an IV line in place, check all your emergency medicines and all the instruments in your OT before you start any cataract surgery. Assign a separate staff for this. In fact, for an emergency team should have 6 personnel, and 1 person should always be recording all the events. And the take-home message which I got is always have another physician or an anesthetist to monitor your patient, however small your surgery may be. So these are the other common scenarios we usually come across at our place. This was a 50-year-old gentleman waiting in the OPD. He was a controlled diabetic, coronary artery disease, and a renal disorder. Suddenly becomes agitated and he falls down. So what do we do? So we normally go ahead, check the air, breathing, the vitals, the blood sugar, and his capillary blood sugar came at 62 milligrams. Sometimes we find that it's very important to get your glucometer calibrated, because we find that these strips are usually out of date, they expire, and they normally don't give a proper reading. And calibrating your instrument is very important, which has to be done very frequently as per the manufacturer guidelines. So hypoglycemia management is very common, and all of us have to be aware of what needs to be done. So treating hypos, I'm not sure whether glucagon is easily available in most of our hospitals, but simply you can go ahead by pushing in a bolus of 25 grams of glucose. The other problem which we commonly face, the cause, is a 34-year-old gentleman presenting to us with 4 seizures in the past. So seizure management is also very important. Check the vitals, make sure that the patient does not bite on himself. Positioning the patient and making himself comfortable, removing screws, is one of the important factors to be considered. So identifying the problem is very important, and making him safe during a fall is also crucial. So acute management of seizures is first that you make him comfortable, loosen the dressing, turn him to one side, look for the ID, and as the seizure ends, make sure that you've done everything rightly. You can make the patient lie down in the lateral position, give him oxygen or pump in lorazepam. And if still the seizures are continuing, you can just load an IV phenytoin and then call for help. Thank you.